Greetings of the day, folks. Today we are going to discuss about CT scores and traumatic brain injury. The first score is Marshall CT score. It has categorized Marshall system places patients in one of six categories, 1 to 6, of increasing severity on the basis of findings on non-contrast CT scan of the brain. Higher categories have worse prognosis and survival. It is primarily concerned with two features: the degree of swelling, as determined by midline shift, and or compression of basal cistern. And the second one is the presence and size of contusions or hemorrhages, referred to as higher or mixed density lesions. The first, as you can see, the category, that is the diffuse injury, and there is no visible intracranial pathology, which is evident on the CT scan. The second category, that is the diffuse injury 2, where there is a midline shift of 0 to 5 mm or basal cisterns remain visible and no high or mixed density more than 25 centimeter cube. Okay, the third category is diffuse injury category 3, where we find midline shift of 0 to 5 mm with basal cisterns compressed or completely effaced, no high or mixed density lesions more than 25 centimeter cube. The fourth category is the diffuse injury 4, where there is shift of midline shift more than 5 mm. There is no high or mixed density lesion more than 25 centimeter cube. The fifth category is evacuated mass lesion 5, where there is any lesion surgically evacuated. It is called as category 5. And the category 6 is non-evacuated mass lesion 6, where we can find, or it is defined as, high or mixed density lesion more than 25 centimeter cube, not surgically evacuated. The second classification that is used commonly is the Rotterdam CT classification, where there is a predictor value and there is a score, as you can see. This classification includes 4 independently scored elements. Like the Marshall system, it includes degree of basal cistern compression and degree of midline shift. It does not, however, include contusions, but rather restricts mass lesions to epidural hematomas and adds intraventricular and or subarachnoid hemorrhage. Each of these is given a score, and these scores are tallied with the addition of 1 to the total. In other words, a completely normal appearing scan has a Rotterdam score of 1, and worst possible score is 6. To the sum of the scores, a +1 must be added, which makes it comparable to the Marshall system. The classification, as you can see, the basal cistern is compared here. When it is normal, the score is given as 0. If it is compressed, the score is given as 1. If it is completely absent or obliterated, it means given as score 2. When there is a presence of midline shift more than 5 mm, it is given as 1. When there is no midline shift or less than or equal to 5 mm, it is given as 0. And epidural mass lesion, when it is absent, it is given as 0. When it is present, it is given as 1. Intraventricular hemorrhage or subarachnoid hemorrhage, if it is present, given as 1, and when it is absent, it is given as 0. So in adults, the mortality at 6 months increases with score. If there is a score of 6, the mortality tends to be around 61%, and if it is 5, score 5, then it accounts to around 53%. If it is 4, 26, 3, 16, and 2, 7%, and 1 is 0%. Note that the initial CT scan done in first 4 hours after admission and not the one with the worst findings, was used for estimating prognosis in the original study. Furthermore, patients with mild head injury were not included in this study. Children have lower mortality in lower Rotterdam score 2 and 3, and higher mortality at higher scores, that is 4 to 6. The next one is the Helsinki computerized tomography score chart. This is somewhat more sensitive when compared to Rotterdam score and also the Marshall system, where the various variables that are used are the mass lesion is divided into 3 categories: subdural, intracerebral, and epidural hematoma. Each one of it is given as 2 except epidural, which is given -3. When there is a presence of mass lesion more than 25 centimeter cube, it is given a score of 2. And when there is presence of intraventricular hemorrhage, it is given as 3. And when there is presence of suprasellar cistons, if it is normal, 0. When it is compressed, 1. Obliterated, 5. Some score ranges from -3 to 14. The probability of 6-month outcome is defined as you can see, there is a formula written here. So it is based on this. And there is also another score, that is the Stockholm CD score. But you can see these are the commonly used scores. You can see the comparative outcomes of this and comparisons among the various scores used of the in the traumatic brain injury patients. Okay, so there is a Marshall system that grades that or categorizes or classifies TBI into grade 1 to 6. Rotterdam classifies it into basals into this, and Helsinki categorizes CTF TBI into -3 to 14. The score ranges in the Rotterdam is minus like 1 to 6. Here it is -3 to 4. Stockholm is traumatic subarachnoid hemorrhage, convexities. Then they tally with this midline shift, whether it is present or not, and when there is a presence of epidural hemorrhage or not, and diffuse axonal hemorrhage or injury. Okay. We'll see one or few examples. In this is this NCCT head of a patient with frontal cerebral contusion. You can see the hyperdensities in the bilateral frontal regions, and there is a hypodensity over here, which is suggestive of edema. And the traumatic subdural hemorrhage, as you can see, concavo-convex. Okay, and it is not respecting the suture lines. This is on the left, and it is hyperdense. So this lesion is suggestive of subdural hemorrhage. And in subdural hemorrhage, it's a crescent shape. And as you can see, at the septum pellucidum, you can see there is a midline shift of 15 mm. So there is mass effect too, which this patient requires immediate surgical intervention. Okay, so categorizing these traumatic brain injuries as important, because to stratify them accordingly, we can, intervene, right? Okay, thank you for watching.